Healthy Conversations is made possible through a grant from the William L. and Ruth T. Pendleton Memorial Fund.
Hello, I'm Dr. Bradley Benson with Dignity Health Yavapai Regional Medical Group, and I'm excited to be here today to talk to you about the physical medicine and rehabilitation, sometimes known as physiatry, and the services that we provide. Okay, so the big question that gets asked me a lot is, what is physiatry? It's not one of those specialties that a lot of people know about. It's like I mentioned in the introduction, sometimes it's known as physical medicine and rehabilitation. Some other terms that you might hear when it comes to my specialty of physiatry is interventional spine care. A lot of us do that type of work, which I do in my practice. This involves minimally invasive injections. Many people are familiar with epidurals as one type of minimally invasive injection for the spine. Also, non-operative musculoskeletal and joint care. We have a big focus on function and quality of life, or obviously quality of care is important too, as it says on the slide. There's not too many specialties that kind of embrace function and quality of life, and that's a big focus of mine is what can I do to improve this person's well-being, looking at the big picture. Ideally, in my practice, we are focusing on the non-surgical type of procedures, injections, interventional spine care like we talk about, physical therapy, exercises, sometimes pain medications. And so all of that translates into a person's quality of life being improved. And so, as I mentioned, more or less, conservative treatment is a big focus, and a holistic approach. We like to look at not only what your pain level is, but also how that affects your life, how that affects your relationships, what kind of nutrition you have, what kind of sleep patterns you have. We really try and look at the whole picture and coordinate that care with other specialists such as physical therapists, occupational therapists, working with the orthopedic surgeon or a spine surgeon, or a primary care physician, rheumatology, et cetera. So there's a lot that goes into kind of looking after a person's function and quality of life. So, important question becomes is, how can physiatry help you? So, some of the services that we provide in physiatry are evaluation and treatment for spine, joint, and neurologic conditions. So, an example of somebody has arthritic knee pain. We can help them get into the proper treatment, whether that's physical therapy, exercises, strengthening, anti-inflammatories. There may arise an occasion where a joint injection becomes necessary, and there are various options that we can offer to you, and I'll talk a little bit more about that later in the presentation. You mentioned spine. So again, there can be arthritic joint pain in the spine, just like in joints elsewhere in your body, such as knees and shoulders. And then neurologic conditions. So my specialty also involves treating people who have maybe suffered a stroke and have what's called spasticity, which is a common condition where there's some pretty bad muscle spasms, for example, in an arm or a hand, and it's really hard to open up the fingers, open up the wrist, the elbow. And so with that type of condition, there are various things that can be done, such as the right physical therapy program, or occupational therapists. A lot of times are working with our stroke patients when it comes to upper extremities, bracing, muscle relaxers, and Botox injections. So that's something that draws a lot of interest in some other lectures I've done or community speaking that I've done, is people are very interested in how Botox can help with spasticity in stroke. We'll talk a little bit more in the other slides, but there's some other uses of Botox, otherwise known as botulinum toxin, as well. And then on the inpatient side, I deal mostly in the outpatient world, again in the musculoskeletal and spine and kind of the pain management side of things. But in the inpatient side there, we take care of people in the subacute phase, meaning maybe somebody's had a stroke or they've had a brain injury. they've had a spinal cord injury, maybe a severe case of multiple sclerosis. And so we are taking care of them. Once they've been stabilized acutely in the hospital, they need help transitioning so they can get home. And again, that involves quality of life and function. So there's a physiatrist may be at a location, an inpatient rehabilitation center, where they can oversee the transition for those patients and making sure that medically they keep everything up to speed, and then also working on them being more functional, walking, getting up and down out of bed, grooming, bathing, etc. So all those little things that sometimes are easily overlooked, rather than that patient going directly home and being a big challenge, we are helping those patients kind of take that transition step for a few weeks to a month to then get home. So just a little bit on the inpatient side. So the physical medicine is more the outpatient, and rehabilitation is kind of the inpatient world. So, okay. So when it comes to the spine-related procedures that we do, they can be ultrasound guided, simple as using ultrasound to inject, for example, a sacroiliac joint, where the sacrum, the bottom of your spine, connects to the pelvis, which then becomes part of the lower extremity. So that's a joint that is problematic for a lot of people, and that can easily be done in the office with ultrasound. And then at the outpatient surgery center, we have a fluoroscope, which is basically X-ray, that we can use to guide a needle carefully into the epidural space and hit precisely, or put the needle precisely where the nerve root impingement and inflammation may be occurring, where there's a disc that might be herniated and pressing up against a nerve. And so that becomes very useful. There are other procedures we use the fluoroscope for, such as a treatment called radiofrequency ablation, which a lot of my patients have heard about already from other patients. That's a method for treating individuals who have arthritic joint pain of the spine. Just like, again, you can have arthritis in all parts of the body. You might have arthritic pain for the L4-5 facet joints. And each vertebrae, as they connect to one another, there are a protrusion from each to the other that allows that connection. There's a right and a left facet joint for every connection between each level of the spine. So that's a very useful technique. It usually knocks the pain out for an individual anywhere from 6 months on the short end to a couple of years on the long end. And there's a couple diagnostic injections that we do with just lidocaine before we would do radiofrequency ablation to make sure that we got the right levels and that that's truly where that individual's pain is coming from before we do that type of procedure. So those are a couple examples. We treat anything from the neck to the thoracic spine, to the lumbar spine, to the sacrum, as I mentioned. So the next one is on the slide is joint or tendon injections. So again, ultrasound is heavily used for that. We sometimes will use fluoroscope, but ultrasound is very handy. It's right in the clinic. And patients enjoy getting ultrasound procedures because they can watch on the screen and see what's happening. And it always strikes up some good dialogue as far as what we're seeing anatomically. And they can see the needle go right into their joint or right into the tendon or near a nerve that we're addressing. And it's a powerful tool that can be used and really make sure that accuracy is there for each of those procedures. And so regenerative medicine, this is an area that's growing a lot in medicine. There's kind of a continuum of different types of regenerative treatments. The first one that's been around the longest is called prolotherapy. And then platelet-rich plasma, also known as PRP, is another treatment that's commonly used. We do a lot of it in our practice, both the prolotherapy and the platelet-rich plasma. And then more new is the stem cell therapy. Not something we're currently doing in our practice, but we're looking into possibly being able to do that in the future. And occasionally I have a patient where maybe we've done prolotherapy, done platelet-rich plasma, and we are considering that needs something just a little bit stronger for a very specific area of the body that could use something a little bit more powerful from a regenerative standpoint. We have connections with other practices that we can send patients to help them get that care that they need. So that's a very nice area of our practice that we provide, because a lot of people know that, okay, I can get a steroid injection and they do really help, and sometimes that takes care of the problems and other times it doesn't, and the problem lingers and it's not doing enough to take care of the actual problem as far as the health of the tissue. And so that's where oftentimes the regenerative medicine treatment options come into play. And we achieve really good results with just the basic prolotherapy and platelet-rich plasma. Very easy to do in the practice. And probably on another day, I'll come back and talk more about the full scope of regenerative medicine, because that's a whole other lecture altogether, if not multiple. So. Okay, so, and then other things that we're doing are, so myofascial pain, that's a condition, a diagnosis that many of my patients have. So what that really means is the muscles or the connective tissue, myo meaning muscle, fascia is the connective tissue. Many of my patients have this condition where there's hurt in muscles in various parts of their body. And sometimes it's hard to differentiate between, is it muscular pain? Is it joint pain? Is it a herniated disc? Is it arthritis? And this, being able to treat people and recognize people that have myofascial pain allow us to really expand and help many more people get to the bottom of what's causing their symptoms. Myofascial pain, we lump it together with neuropathy or neuralgia as well, because they very often go together. Because if you've got muscle tension, if you've got, just sore muscles that are inflamed, they'll kind of get tense up and pinch down on a lot of these nerves that are closer to the surface rather than the lumbar nerve roots or the cervical nerve roots, which are deep, where we do an epidural to treat impingements there. These are nerves that are impinged more on the surface. They can be in the shoulders, hips, low backs, neck, especially the low back and the neck region, shoulder region. We are treating, and the hips, treating lots of myofascial pain, lots of neuralgia or neuritis per se. And then we also do a lot of nerve blocks. So very common, and most of you are very familiar with the term carpal tunnel syndrome. So at the wrist, the median nerve travels through here and it can get pinched. There's a ligament that runs across here, the transcarpal ligament rather. Tarsal's for the ankle, so transcarpal ligament is right here. And so we can, and the nerve, if you're doing lots of squeezing and gripping and fingering, there's various things that are repetitive motions can cause friction and inflammation on the median nerve. And so we'll use ultrasound and we can see right where the median nerve is, and then set the needle right next to it and inject an anti-inflammatory solution, nerve blocking solution in there that does wonders from a non-surgical approach to treat a person's carpal tunnel and get rid of that numbness and tingling that they're having that's keeping them up at night and making it difficult for them to sleep. So one example of a nerve block, there's many other entrapment syndromes that we're using ultrasound to guide on for treating those neuropathies. So physical rehabilitation oversight. So I'm here for Yavapai Regional Medical Group, Dignity Health. I oversee the physical medicine services that are provided. So I meet, depending on how busy I am and they are, we meet periodically to work together on the things that are happening in physical therapy, occupational therapy, speech therapy, etc. And oftentimes we're working together to come up with ways to improve patient care, and as well as check in with one another and see how patients are doing that I've maybe referred to them or they've recommended to come see me. So that's a nice way where we're combining the conservative, kind of the beginning of the conservative continuum of ice, heat, anti-inflammatories, and then they get into physical therapy. And then if we're not getting enough progress, then we have to look at some injection options that may be pertinent, some muscle relaxers, maybe there's some other medications that we can prescribe to get a person through their challenges. And a lot of the time, that's where we achieve a lot at that stage. But occasionally, there are some conditions, inevitably, that may require surgery. So we are very equipped to identify those patients after they've exhausted conservative care and then help get them to the right location, whether it's orthopedic surgery, whether it's spine surgeons such as neurosurgery. We can help direct that care. So I mentioned a little bit earlier in the discussion, Botox treatments. So I mentioned post-stroke spasticity. I talked a bit about that, and that's very helpful. It can, again, we inject into those muscles with that Botox, and it helps relax them. It basically works at the neuromuscular junction, blocks acetylcholine from going across that membrane, and it can relax those muscles for a long period of time. Botox can be repeated as often as every 3 months. So there are some patients that this is a maintenance thing that allows them to improve function, more easily get on their shirts, help with hygiene because they can clean between the creases if they're not stuck in positions like that. Spasticity often affects the leg too. It makes it very difficult to walk because the foot's kind of pointed, the toes are pointed down and in, and it's very difficult to get a shoe on. And so we can use Botox along with the other modalities such as physical therapy, bracing, muscle relaxers, et cetera, to get people walking again and more functional and, again, quality of life. So chronic migraines, we treat a lot of people that they've already exhausted medications to try and prevent the migraines. They're taking the medications that help get rid of acute onset migraines. And so we can help identify those who have chronic migraines and then for the appropriate patients, use Botox to inject in several of the muscles around the head and kind of the upper neck to help relax all those muscles and allow the migraines to greatly subside. Acts as a really good preventative kind of maintenance thing. And a person might go from having 15 to 30 migraines a month to having maybe one or two breakthrough migraines that may still happen. A lot of patients have almost no migraines will occur after they've had their Botox injections. And Botox, again, can be treated, or the treatment can be done every 3 months, or sometimes we stage it out longer than that. It just depends on the patient's need and kind of track record for how long it lasts. Cervical dystonia is another one. You might have heard the term torticollis, where a person has some involuntary muscle contraction that turns the face and chin the opposite direction, and they can't quite get their face to come in a straight, aligned forward position. It can be very uncomfortable. You can imagine trying to hold your head in this position and not really being able to get it to come back to how you would like it, as well as just people who feel embarrassed in public because I can't get my head straight. And if there's a lot of stress, if they have not getting enough sleep, if it's cold outside, there's a lot of other things that can cause that kind of dystonia to get worse and become more obvious. Sometimes often a little bit of a head tremor will happen with dystonia. And that, again, is something else where we can inject the affected muscles and really help improve a person's quality of life and reduce their pain a great deal. And so we have I've been with Yavapai Regional Medical Center, now Yavapai Regional Medical Group, Dignity Health, for the past 9 years. And during that time, I've been fortunate to work side by side with neurosurgery, where on the physiatry side, we are working hard on the conservative management side of it, all the types of things we've more or less talked about. And then we've got neurosurgery that's in our same office and has worked hand in hand with us, who can manage the surgical side of it. So again, maybe the epidurals and the physical therapy and the other things we were doing, there's just too much of a narrowing in the spine, something called spinal stenosis that a lot of patients get, where they just need to have some surgery to go in and open up that space, make it bigger, allow that nerve to breathe. And then there may come a time when they need to come back and re-up on some of the conservative care, the physical therapy. And so it's been nice because we can talk with each other in the hallway, and we really kind of collaborate as a group to make sure patients are getting the best care, and all treatment options are available to them on the table, and we can educate them and get them the best care possible. We're advocates for the patients, and our goal is to ensure that you receive the care that's right for you. We don't want someone, realizing that maybe they have sciatica, they got a pinched nerve, and going right to surgery. In most cases, 95% of the cases that acute sciatica develops, or a pinched nerve, what we call lumbar radiculopathy, very rarely do they need to go right to surgery. And it's better if you start on the conservative side of things with physical therapy, the right exercises, stretches, some medication, maybe an epidural. And a lot of time, most patients are going to improve with a lumbar radiculopathy, a lot of people know it as sciatica, without having to go the surgical route. And of course, I'm trained, and those that I work with, we're all well trained to identify patients that maybe have some red flags. There are times when a person comes in and they may have some things like bowel and bladder control are affected. They have some pretty prominent weakness that's developed, very dense numbness and tingling. And we have to really, at that point, pretty quickly consider getting them over to our neurosurgery colleague and consider where their surgery may be needed at that point. But that is less often than, again, the 95% of the time, we're able to start addressing these patients from a much more conservative approach. So it is, again, the resources, we are we know the practitioners in the community really well that are, again, in physical therapy and occupational therapy, massage, chiropractic, all those areas that we can help also facilitate those relationships and those referrals. And we want to use every tool available. We don't necessarily want to try one tool, that didn't work, move to this tool, that didn't work, move to this tool. It's better if we're kind of including physical therapy while we're starting injections. Maybe they're getting a massage In some cases, maybe we're getting just a second opinion from neurosurgery to have them kind of weigh in and see what they think in cases that are a little bit more difficult, as I've mentioned before. So, and again, this really allows us to empower you as patients to achieve your best function and quality of life. And I mean, patients who move to this community, oftentimes are coming here to retire, but they have a lot of good years ahead of them. They want to be playing pickleball, they want to be golfing, they want to be hiking, running. And so we take a lot of pride in our practice in helping those individuals sustain that type of lifestyle that they want and helping them through the bumps and the bruises and to keep going and staying as active as they can, because activity, nutrition, exercise is very good medicine. We want to kind of remove those barriers to keep people going in that direction. Okay, so, and we work very hard to make sure that we're addressing urgent surgical needs quickly. So again, when we identify those red flags, we're gonna move them on to neurosurgery. And also rather than a person having back pain that becomes chronic, we wanna catch people who have back pain in an early stage when it's more acute and it's just starting to really affect their life. We prefer to see patients as soon as we can because you can affect change a lot quicker. So we talked about how it's very important to us that we make sure that you understand all the treatment options that are available to you. And we encourage patients to come to us with questions that you have. We like to hear things that you're reading about or learning about, and we're happy to discuss those things with our patients. So currently in our practice, there's myself at the top there, Kelly McLaughlin. She's a nurse practitioner that's worked with me the past 3 years. Excellent. Before she came to work with me in physiatry, she had some good experience in emergency medicine as well as family practice. And then we've got Jeremy Platt, who's worked in the neurosurgery realm. And then we have Lee Abbott, who's also worked in primary care and worked in emergency medicine, like Kelly, and again, brings a lot of knowledge of musculoskeletal medicine and spine, knowledge of spine to the practice. We've got a really well-rounded group. We work well together, and we are excited to offer care. So that question does depend a lot of times on one's insurance. So Medicaid insurance is typically needs you to have a referral and have the primary care physician sign off on that referral. And so they kind of help patients get those referrals to us. There are some of the private insurances also may require a referral from a primary care physician, but probably 50% of insurances can be self-referred to us, and they can call us up and say, hey, I want to be seen, or so-and-so recommended that I come see you. And then they can come to our practice, or we can email them the new patient packet and they fill that out, return it to us, and then we can schedule an appointment at that point. We try and make it as easy and seamless as we can. Yeah, so a lot of it is overseeing, again, the big picture and making sure that a person is not just getting injections, but they're also maybe doing some stretches and some strengthening exercises at home. Sometimes people have dealt with pain, for example, for a long time, and they might be depressed or anxious, and so we can help them with a referral to a psychologist to kind of help manage them that way, which does a lot, believe it or not, oftentimes to help a person's pain. Again, it might be a nutrition problem, it might be weight loss, and so we can help troubleshoot that. Some things we manage directly in the practice, other things we help with the appropriate referral, and then we're kind of overseeing, again, the massage therapist is helping us out, the nutritionist is helping us out, the physical therapist. So we kind of work, that's kind of how we kind of provide that holistic approach to helping make sure that patients are healing as best as they can. Okay, so for a first appointment, whether it's to see me or to see Kelly, Lee, or Jeremy, we just want to do a basic overall history and physical that's pertinent to the complaints that you have. Maybe it's joint, maybe it's spine, maybe it's a neuropathy, etc. So we are going to do a detailed history and physical, and we're going to try and get all the pertinent records we can. Particularly imaging is helpful to have. So we encourage patients when they come for that new patient appointment to bring recent images that they have. Maybe they've had surgery, so if they want to bring records documenting prior surgeries. We typically, when we get a referral, are going to automatically get the last history and physical from that physician that referred the patient. And so we take all that information that we have and we talk to you and we kind of put the pieces together, do a thorough exam, and then we make our recommendations. And we talk about maybe other diagnostics we might need to do to arrive at the right diagnosis, to then know how to best treat you. And then if we are that far, then we'll start mentioning already the treatment options that are there for you. And for us, it's very important to have a collaboration between you as the patient and us as the physician. We don't necessarily want to, force anybody to make any. We want patients to feel like this is a team effort, because people already know oftentimes when they come through the doors that there are certain things they don't want to do and certain things they do want to do, and so we can kind of talk that through and kind of find the right match. And sometimes there's, you could start with this, you could start with that, you could start with that. And so there are oftentimes options. We just make those available to the patient so that they are empowered to make the right decision for them. Is we are the only specialty that doesn't own a particular part of the body. Most specialties, for example, the kidneys or bones or hearts or lungs, etc. Whereas physical medicine and rehabilitation, we're kind of looking at the patient in its entirety. Particularly, there is more focus, of course, on the neuromusculoskeletal systems. And so we look at that and try and determine how we can, again, maximize a person's function, quality of life, keep them doing the things that they want to do. Maybe there's adaptations we have to introduce, bracing. Some patients may need a walker, a wheelchair, etc., to kind of get them moving forward with their life. Maybe it's the injections to manage their pain. Maybe it's medication. So all those little things that sometimes don't get put together and seen at the same time, we're offering to patients. So that's something very unique about physical medicine and rehabilitation. So I appreciate everyone tuning in today for this presentation about what physiatry is, what services that we provide. And we look forward to having you come visit us in the practice, even if it's just for a consultation, to know more about what treatment options may be available to you, to get an opinion on what the cause or what the diagnosis may be. And we have a plethora, we have lots of options to offer patients. That's something I'm very proud of, is it's not just a couple tools that we have quite a range of tools and options that we can use diagnostically as well as treatment and providing that advice that may be needed. So, and also if you'd like to know more, our phone number is listed on here for the practice. And then you can also go to yrmchealthconnect.org where this presentation is posted and learn more about us. And we anticipate in the future doing some more of these to talk about in greater detail about some of the topics that were discussed earlier in this presentation. So thank you very much.